Greetings from Doha, the host city of the World Cup 2022, which will be just about less than 3 weeks from today. This is Ziad Hijazi from Sidron Medicine. First, my deepest apologies for not being able to be with you in person, but this is the next best thing. Today, my talk is about transcatheter occlusion of coronary arteriovenous fistulas as well as pulmonary AV malformations. This is my disclosure slide, which is non-related to this talk. We're going to start with transcatheter closure of coronary arteriovenous connections. Coronary arteriovenous connections are communications between the coronary arteries and the cardiac chambers. The other name is coronary cameral fistulae, or the other vessels, coronary arteriovenous malformations. Just to let you know that we have written a recent article about congenital aortocardiac connections, and in this article we have revisited the naming of these fistulae or connections, and based on the type of connections we devised a treatment strategy. I advise all of you to download this article and read it so that you can understand this concept very well. In that paper, we divided the congenital arteriocardiac connections into the type of connector, whether it's a hole or a channel. If it's a channel, anatomic type 2, or extra anatomic type 3. If it's extra anatomic, it's either intramural or extramural. And you will see in this the type of connection is that type 3A and type 3B. The etiology of these connections, most of the time it's congenital, but on rare occasion it is acquired after a trauma, a stab wound or a gunshot or a projectile injury. The incidence of coronary arteriovenous connections is about 0.3% of all forms of congenital heart disease. In adults who undergo coronary angiography, the incidence between 0.13 to 0.22% of all patients undergoing coronary angiography. Most of them, of course, are asymptomatic. Based on the origin of the connection from what artery, majority are from the right coronary artery, 55%, the remainder 35% from the left, and of course the rest of the percentage is combined origin. The drainage site, majority of them into the right ventricle at 40%, 26% into the right atrium, 17% into the pulmonary artery, and the remaining percentage is multiple drainage sites. The sequelae of these connections, they may lead to ischemia and angina. If they are large, they may lead to heart failure and cardiomyopathy, sometimes myocardial infarction. They may lead to pulmonary hypertension, end arteritis, rhythm disturbance, thrombosis, and rarely rupture of these fistulae. Management decision in these patients, it depends on the size of the fistula, presence of symptoms and complications, the age of the patient, the anatomy of the fistula, and presence of other indications to undergo invasive procedures. We've written a paper in circulation about recommendation for coronary arteriovenous fistula, as you can see, divided into class 1, class 2A, and the class 3. Class 1, if there is a continuous murmur, the origin should be defined either by echo, MRI, CT angiography, or cardiac catheterization. If you have a large fistula, regardless of symptomatology, this should be closed via either transcatheter or surgical route, or if you have a small to moderate fistula in the presence of documented myocardial ischemia, arrhythmia, and otherwise unexplained ventricular systolic or diastolic dysfunction or enlargement or end arteritis, these should be closed via either a transcatheter or surgical approach. In class 2A, if clinical follow-up is indicated with echo every 3 to 5 years, can be useful in patients with small asymptomatic fistula. Class 3, which means you should not do anything if patients with a small asymptomatic coronary fistula. This diagram gives you a flow chart what to do with coronary artery fistula. On the left-hand side, if they are proximal fistulae and it's medium to large, plus minus symptoms, the patient should undergo closure, either transcatheter or surgical closure, plus anticoagulation. If they are small with no symptoms, obviously you may need just to do observation of these patients. You may give them anticoagulation. In these cases, they do not need anticoagulation or antiplatelets. If it's distal fistula, again, you look at the size. If it's a small, just observation and no need for anticoagulation. If they are medium to large, with or without symptoms, obviously you need to do intervention, either transcatheter or surgical closure, plus anticoagulation or antiplatelet therapy. So depending on the size of the fistula, you look at the relative size. You may measure the QP to QS, QP-QS ratio, but I want you to be aware that the amount of blood that supplies the entire heart, which is the coronary flow, is about 5% from the entire cardiac output. So QP-QS in the majority of patients will not be large, except if the fistula is really huge, similar to the case that I will share with you later. Also, you look at the aneurysmal dilatation or tortuosity of the fistula. Based on the symptoms, if they have heart failure, like one neonate presented to us with severe heart failure, but in 50% of symptomatic neonates, they may become asymptomatic with size of fistula decreasing over time. There is a spontaneous closure has been seen in some patients. Also, angina, arrhythmia, shortness of breath may be seen in adults, and endocarditis is rare at 3% of the patients. Age of the patient, again, as I mentioned, spontaneous regression in some patients with advancing age. Size and developmental maturity of patients is important. Elective closure in children with medium to large fistula is reasonable. As I mentioned by the indications, it's class 2A. Presence of other congenital heart disease, indications for surgery or transcatheter in some patients with tetralogy fellow, PDA, ASD, pulmonary atresia. This is present in 10 to 30% of the patients. Surgery for closure of these fistula has been first performed in 1958. External closure versus intracardiac closure, mortality is very low, but there is recurrence or incomplete closure in about 10%. Catheter intervention goes back to 1983, very low mortality. At that time, many devices have been used, from detachable balloons, Gianturco coils, Rashkind umbrella, Amplatzer devices, and most recently we have been using Amplatzer vascular plugs, as well as covered stents if there is multiple exit sites for these fistulas. Closure in the cath lab is applicable for more than 90% of the patients. There is a chance of a small residual or recurrence of the fistula in about 10% of the patients. Technique of closure, either you can go retrograde with coaxial technique using coils or vascular plugs, or we close it anterograde. In these patients, you will need to create an arteriovenous loop. Let's discuss the retrograde approach. This is a case of a 48-year female patient with large circumflex to coronary sinus fistula. She presented with shortness of breath and fatigue. We closed her fistula successfully using 6 coils. 2 Nestor coils and 4 Gianturco coils, and she was discharged home the following day on no medications at all. And I am emphasizing here on no medications because you will see now what happened to this lady. So this is the angiogram. You can see the circumflex to the coronary sinus drainage, and this is the angiogram after 6 coils. The circumflex is patent and the other branches are patent as well. 4 days later, she presented to the emergency department with chest pain. Therefore, she was diagnosed to have myocardial infarction. Repeat angiogram, complete occlusion of the left circumflex coronary artery. Look at this angio. There are the coils, and of course, no circumflex because it was occluded completely by propagation of the clot proximally. This is a very serious issue, and that's why these patients need to be placed on either anticoagulation or antiplatelets. This is a child 4 years of age with LAD to RV fistula. So we did retrograde with a 4 French catheter. Then we put a tracker catheter inside the 4 French catheter or a micro catheter. We put a balloon tipped catheter there with occlusion to delineate the exit as well as the myocardial viable branches. The first coil was detachable coil 8 mm by 20 cm. There is the angios. Then second coil, similar size, 8 mm by 20 cm. Then we kept putting coils in this patient until we occluded the fistula completely. The videos are playing for you, showing you the deployment of all these third and fourth coils, 4 mm by 8 cm. You can see angio, there's still some flow. Then the fifth coil was 6 mm by 20 cm. The goal usually is to achieve complete closure in the cath lab. On occasion, when there is trivial residual leak, we don't go after it because we're confident that this will close with time. And you can see here complete occlusion. Obviously, you can see the slow flow in the LAD. So this patient, it is extremely important to put her on Coumadin and bridge her to warfarin for 6 months until the fistula completely closed and there is good flow, and then we bridged her to antiplatelet for the remainder of her life. The anterograde approach, you will need to establish arteriovenous loop, and this is an example in this case. 2-week young female neonate with very large fistula. She weighs 2.3 kilograms, but she was presented to us with severe heart failure. And we performed cardiac catheterization from the left femoral artery, 4 French, left femoral vein, 4 French, and the right internal jugular, 7 French. So obviously she had systemic PA pressure. The QPQS was infinite. We used the first device, a 12 mm Amplatzer muscular VSD device and 7 flipper coils. There was still significant residual shunt. We brought here for second cath. We get access from the left femoral vein, 4 French, left femoral artery, 4 French, right carotid cut down, 8 French. We reassessed the pressure, still elevated but better than before, and the QPQS was definitely better but still massive, and we put additional devices, 10-8 duct occlude, as well as 8mm Gianturco Grifka vascular occlusion device. By the way, this device now ceased to exist because the manufacturer stopped manufacturing it. Repeat QPQS after all of this came down to 3-1, and this patient now is alive after 15 years from this cardiac catheterization. This is the first angio. Look at the size of this fistula, massive fistula. So we crossed and snared from the IJ. You can see the snaring from the IJ. And then we put a large sheath from the right IJ, 7 French, and then we deployed the Amplatzer muscular VSD device at 12mm as distal as possible. And then after we released this device, on top of it, we deployed 7 coils. But after that, and because we gave a large amount of contrast, we stopped and we brought her back after a couple of days, and we closed the remaining fistula with other devices. I'll let this play so that you can see there's the coils. That's the end of the cardiac cath. Then the second cath, as you can see, I'm putting now the PDA device from the right carotid artery. Then on top of it, I put a Gianturco Grifka vascular occlusion device. There is the Gianturco Grifka vascular occlusion device. And then the patient did very well. And the final angio, you can see the remainder of the coronary arteries, they fill very well. And as I mentioned, this child is over 15 years of age now, doing extremely well, and she continues to receive a baby aspirin for the rest of her life. Long-term outcome, the majority of these patients, they do well. Small residual leaks in about 10%, persistent dilation of the coronary artery, late stenosis, arrhythmias, acute or late occlusion with or without myocardial infarction. Follow-up is mandatory, and appropriate tests should be done for these patients to look at the coronary arteries. Now let's shift to pulmonary arteriovenous malformations. These are direct connections between the pulmonary artery and the pulmonary vein. So we bypass the capillary bed, therefore no oxygenation. So this results in right to left shunt. When you have right to left shunt, this may lead to hypoxemia if it's large, dyspnea, paradoxical emboli that may lead to stroke, cerebral abscess, myocardial infarction, or sometimes you may have pulmonary hemorrhage due to rupture. This condition is associated with hereditary hemorrhagic telangiectasia in 47 to 80% of the cases. Endovascular occlusion is the preferred management for these patients. Nowadays, rarely we perform surgery, but if they are diffuse, you may need to do lobectomy or entire pneumectomy. Etiology. Again, congenital in the majority of the patients, and as I mentioned, 80 to 90% are associated with hereditary hemorrhagic telangiectasia, which is Osler-Weber-Rendau disease. They could be acquired, especially in patients after chest trauma, after the Glenn shunt, the Kawashima procedure, hepatopulmonary syndrome, or congenital portosystemic shunts. The European guidelines in 2019 for management, if the feeding artery is 2 millimeters or larger, they intervene. If they are increasing in size, they intervene. If the patient had a paradoxical embolism, they intervene. If the patient develops symptoms of dyspnea, they also intervene. This is a patient who had a couple of fistulae, pulmonary arteriovenous malformations. We access the femoral artery. We deploy a sheath as distal as possible, repeat the angios, then deploy devices as distal as possible to eliminate the right to left shunt. You can see here we put Amplatzer devices and Amplatzer plugs to eliminate the right to left shunt. this patient improved, but when this patient presented to us, she presented because of paradoxical embolism. This is a flow diagram showing that if symptomatic patients like epistaxis, dyspnea, hemoptysis, TIAs, stroke, or they could be asymptomatic, incidental finding, or if they have hereditary hemorrhagic telangiectasia, you screen them with chest x-ray, sometimes with oxygen saturation, with arterial oxygen content, and you may also, if these tests are all positive, you may do a chest CT. If they are negative, you stop there. If the chest CT is positive, you look for pulmonary AVMs. If they are large, you may need to do something. If they are small, you may just follow these patients up. So it's extremely important that you do your workup completely for these patients upon presentations. So in conclusion, coronary arteriovenous connections are not uncommon. Knowledge of indications when to close is important. Knowledge of the size, site of drainage, and available devices should help in managing these patients. Working with our colleagues in adult cardiology for these coronary fistulas is extremely important because they know about coronaries more than the pediatric cardiologist. So it's important to work with them. Also, for adult patients, it's important to put them in the adult CCU so that if any EKG changes, enzyme changes, or symptoms, intervention can be activated immediately. Also, these patients, they require anticoagulation or antiplatelets. Pulmonary AVMs, the same thing. We would like to work with our colleagues in interventional radiology because they have materials that may not be readily available in the pediatric cath lab. Again, knowledge as to when to intervene is extremely important. Thank you for your attention, and I hope that you will join us in the PICS Symposium, which will be held in Istanbul in March of next year. Thank you again.